I don't think very many people need an introduction for Dr. Jennifer Miller. And we're really sorry that she's not able to join us today, but I was going to say thanks to the wonders of modern technology, but some of modern technology seems to have slightly outfoxed us. Dr. Miller is Associate Professor of Pediatric Endocrinology at the University of Florida. Dr. Miller's research focuses on treatment of individuals with Prader-Willi Syndrome and early onset obesity. The majority of her research efforts are currently focused on identifying the cause and possible treatment for hyperphagia in Prader-Willi Syndrome. She's been working with individuals with Prader-Willi Syndrome and early onset obesity for the past 18 years. She currently follows over 400 patients with Prader-Willi Syndrome from all around the world and over 100 patients with early onset morbid obesity from across the USA. She's currently working on developing clinical treatment trials for individuals of all ages with Prader-Willi Syndrome. I think you also know it's an extremely early hour where Dr. Jennifer Miller is, so we are particularly grateful that she's with us. Thank you very much, Dr. Miller.
I am so sorry that I'm not there. I really, truly apologize. And maybe you'll invite me back in 2 years and I'll come in person, because that would be lovely. I am going to talk to you today about oxytocin trials in Prader-Willi syndrome. Patsy said this was a topic that you guys were potentially interested in hearing about. I made the presentation purposely kind of short so that you can ask questions, and hopefully I can give you some answers to some of those questions as we go along. So feel free to either interrupt me, although I'm not sure how you're going to do that exactly because I can see you, or to save your questions for the end, either way. So oxytocin. Oxytocin is a hormone that is synthesized in the hypothalamus. There's two areas of the hypothalamus primarily where oxytocin is made. Oxytocin then has to go and be stored in the posterior pituitary gland. We know that hypothalamic problems are part of Prader-Willi syndrome, and so oxytocin for years and years has been hypothesized to be one of the problems in Prader-Willi syndrome. Receptors for this hormone are found throughout the body, both in the central and peripheral nervous system, in the heart, the GI tract, the kidney, and the brain. Oxytocin's function in our lives is to mediate our social behaviors. It increases our trust, and it actually facilitates positive physiologic and psychological responses to stimuli. So in other words, it's our love hormone. It's our bonding hormone. Dick Schwab back in 1995 did some autopsy studies and found that there was a deficit in oxytocin producing neurons in individuals with Prader-Willi syndrome who had died from various causes, things like car accidents, illness, things like that. So from then, it was postulated that perhaps the deficit of oxytocin in Prader-Willi syndrome could be contributing to hyperphagia and some of the other conditions that we see in our individuals with Prader-Willi. When you talk about oxytocin, it's important to talk about its sister hormone, which is called arginine vasopressin, or AVP. So these hormones are small, they're very closely related. They're both made in the same areas of the hypothalamus and stored in the same areas of the pituitary gland. Interestingly, AVP in males is made also in other brain regions besides just the hypothalamus. There have been a lot of studies that are ongoing right now looking at both oxytocin. Patsy, you don't have to stand there and watch me if you don't want to. There have been a lot of studies that are looking at the dysregulation of both oxytocin and AVP in terms of multiple different conditions that affect social interaction. So people are looking at these for things like autism, schizophrenia, even compulsive and obsessive behaviors like gambling or smoking or things like that. Interestingly, the reason why these two hormones matter is that because although they are closely related, they actually have opposite functions in terms of social functioning. So while oxytocin increases our trust and our bonding, AVP actually increases our sort of paranoia. It increases our arousal and defensive behaviors by increasing the sympathetic nervous system response to stressful stimuli. So they're very interesting hormones. They're super, as I said, closely structurally related. However, their actions are very different. And so on this slide, I've contrasted both oxytocin and arginine vasopressin. And I want you specifically to look at the central actions of oxytocin versus the vasopressin. So oxytocin decreases aggression, particularly females versus males. It decreases anxiety. It increases relaxation, well-being, and trust. It increases initiation of social contact. This is important for mothers and babies to bond. It increases both pair and social bonding, and increases one partner preference formation, so falling in love, if you will. Again, this action is more potent in females versus males. Now, vasopressin is actually more potent on its effects in terms of males versus females. So it increases things like aggression and territorial behaviors. It increases anxiety. It increases attraction and partner selection, parent social bonding, and partner preference. So these are both important hormones, and we know that there is a disruption, and I tell patients all the time, there's a disruption in this whole system, in both the oxytocin and the vasopressin system. The vasopressin system, just so you know, is the part of the brain that actually regulates primarily our salt and water balance. And so anybody who has a child with Prader-Willi syndrome knows that this is clearly off, because the children don't have a desire to drink plain water. They aren't thirsty in a typical way. And so we know just clinically that the whole system is not working appropriately. Dick Schwab's autopsy information showed us that there's a reason for that these neurons are not present in the same numbers in the hypothalamus as they are in other people. But I always say, you know that it's broken just by looking at the kids, because they don't like to drink, they don't have a normal thirst, and they will dehydrate themselves if they choose not to drink. Whereas you and I couldn't do it if we wanted to, because our arginine vasopressin system is set up so that we don't get dehydrated. So although there are very specific receptors for both of these hormones, again, they have this very close evolutionary relationship. They're very, very structurally similar molecules. And so there's a lot of crosstalk between these systems. And at high levels, oxytocin and vasopressin, or arginine vasopressin, which I'm going to call vasopressin from now on, can be partial agonists for the other's receptors. In other words, if you have too much oxytocin, you can start to bind the vasopressin receptors. And these pathways then can interact. So you can actually upregulate vasopressin receptor activation with an overdose of oxytocin. So, well, by giving oxytocin, you may think, okay, we're going to decrease anxiety and increase bonding. If you give too much oxytocin, you can actually go the other way and increase paranoia and behaviors and temper tantrums and those kind of things, because it's now binding to the vasopressin receptor. We know that each individual is an individual, and everybody has differences in their oxytocin receptors. A lot of what determines our oxytocin receptor availability and how oxytocin can bind to our receptors is things that happen very early in life that in general we have little control over. It's the bonding between a mother and a baby. It is the method of birth. It is feeding, breastfeeding versus bottle feeding. There's a lot of different factors that contribute here. And it's thought that those pathways and those receptors are set by about 6 months of age. Now, does that mean that you can't, give oxytocin later in life and change some of this? No, it doesn't mean that at all. It just means that the critical time for intervention seems to be prior to 6 months of age. And then, later on, oxytocin can be used, but as a treatment rather than changing the natural history of things. So we learned a lot about oxytocin from mouse models. So mouse models started as a model for autism, which, as many of you know, has very similar characteristics to Prader-Willi syndrome in a lot of ways. And when a mouse model was made that was deficient in the oxytocin receptor, what people saw was a decreased cognitive flexibility and a resistance to change. from a learned pattern of behavior. And again, anyone who has a child with Prader-Willi knows that this is exactly what you see in children with Prader-Willi syndrome, is that they become very resistant to change in their patterns over time. Rachel Webrick in Canada and then Francois Muscatelli in France both created what's called a MAGEL2 knockout mouse. It is considered one of the mouse models for Prader-Willi, although it doesn't recapitulate everything that happens in Prader-Willi syndrome in humans. It's a nice model because it knocks out one of the critical genes that is known to be associated with Prader-Willi syndrome. Interestingly, in humans, if you just knock out MAGEL2, you get a different condition called Shaff-Yang syndrome, which is associated with autism and feeding difficulties early in life, but not with the hyperphagia and obesity later in life. And that's the same thing that's recapitulated in this mouse model. So you get the autistic features in terms of decreased cognitive flexibility, resistance to change, resistant to explore novel environments, resistance to making new relationships, but they don't get the hyperphagia and obesity. Anyway, what they found in this knockout mouse was that there was a reduced number of oxytocin receptors in the mouse brain, specifically in a region of the brain called the lateral septum, which is a region that is really important for conditional learning, for fear, and for anxiety. Again, recapitulating some of the social things that we see in individuals with Prader-Willi syndrome. The mice, the MAGEL2 deficient mice, have a reduced interest in making new partners, in making new friends, in exploring novel objects. And in addition, the male MAGEL2 knockout mouse displayed altered spatial learning, so had difficulty learning new visual spatial tasks. There's been a lot of mouse data, and I didn't feel like taking your time because I feel like this is more, since it's mostly parents there, that this is more of a clinical talk that you wanted to hear. So I just wanted to give you one additional slide on mice, and then I promise I'll stop and talk about people. But the mouse data has taught us a lot. And what it specifically taught us was, even if you're missing these neurons, even if you're missing MAGEL2 or you're an oxytocin receptor knockout mouse, when you give oxytocin to these mice, actually you then improve the social deficits and behavioral rigidity. So again, even though we think that early in life is a critical time to intervene on this system, doesn't matter, because you can still make things better by giving oxytocin later in life to these mice and also to people. So the findings in mice were really exciting for those of us who deal with people rather than mice, because they suggested to us that oxytocin may be really important for individuals with Prader-Willi syndrome, and also with that other condition called Shaff-Yang syndrome, which is just a MAGEL2 deficiency, so one gene in the 10 that are involved in Prader-Willi syndrome. So in humans, oxytocin studies have been going on since the late 90s. Oxytocin is one of those hormones that has sort of come and gone in popularity and is currently sort of a hot topic, but has been before, and again, has come and gone through the years. Intranasal oxytocin was originally marketed by Novartis to increase breastfeeding. So it does play a role in the milk letdown that happens when you're breastfeeding a baby. And so it was on the market and available for that reason. And people started looking at it because it was known as the love hormone, the bonding hormone. And so they wanted to see, could it make you trust somebody more? If I gave you oxytocin, would you believe what I'm saying more than if I did not? And what they found was indeed that it did. When they gave it to men who they were playing games with money and lending money and monopoly kind of games. And what they found is that men who took oxytocin intranasally had better prosocial behaviors and more trust of other people. They were much more happy to give others their money, trusting that they would give it back to them. Intranasal oxytocin also has been shown, especially in other syndromes, to improve the gaze toward the eye region of the face. We all have seen individuals with Prader-Willi syndrome who, when you ask them, did they take that food, their eyes are everywhere but your eyes. and they're looking, everywhere. And intranasal oxytocin actually helps improve that eye contact from person to person. Again, other syndromes have this issue as well, not with food necessarily, but just with the eye contact, and it is associated with autism as well. And so it was a very important feature that was discovered, that by giving the oxytocin, you could get these individuals to look you in the eyes. That actually then translated into improved facial memory, enhanced sort of ideas of social cues. So social cues became more important. Again, we all have seen children that are close talkers, that stand right up on you and don't recognize that you're uncomfortable with that behavior. And what the intranasal oxytocin did was make them realize, oh, this person is uncomfortable, I need to step away. And so it was a really interesting finding. They found that specifically in a syndrome called Fragile X syndrome, which has a lot of autistic features as well. And then there's also something called reading the mind in the eye. And it's a test that's done on the computer where they show just a picture of eyes expressing different emotions. And individuals, both with Prader-Willi syndrome and other syndromes, after the administration of intranasal oxytocin, were able to decipher those emotions much, much, much better than they were without it, just from looking at the eyes. And again, this is important for social interactions, for how you respond in your community and how you interact with other people. Again, it has anxiolytic effects, which I think is, to me, one of the hugest possible effects in Prader-Willi syndrome, because we all know that anxiety is a big part of Prader-Willi syndrome. It does improve social interactions, reduces fear, and improves the ability to pick up on these subtle social cues, like the looking at the eyes. Now, Patsy, I added this slide for you because we were talking about sleep by email the other day. Oxytocin is also important for many other features. And one of the things when we were doing our first oxytocin study that we started talking about was, well, two things. One, sleep, and two, the GI tract. So these are both features that we all know can affect individuals with Prader-Willi syndrome. So, well, it's all great to try to help the appetite and the anxiety. Anyone that knows me knows that I'm very holistic and I'm all about the whole child, the whole person, not just one piece of them. And sleep is a very important part of a lot of the behaviors that happen in Prader-Willi syndrome, as you know. So individuals with Prader-Willi do have sleep disruption, both obstructive and or central sleep apnea in many cases. So this is a study that was not done in Prader-Willi syndrome. It was done in regular, people who were unaffected, but did have obstructive sleep apnea. And I thought it was super interesting. So they took 8 individuals who had obstructive sleep apnea. And as part of the study, they actually had them fill out some mental health questionnaires as well, because we all know that when you're tired, you're grumpy, you can be depressed. Sleep can interfere with your well-being, and depression can interfere with your sleep. So they go back and forth. So they had these individuals fill out these surveys, and then they did sleep studies, which anyone who's been through it with their child knows how super fun those are. But what they did was that they did a sleep study, and some of the people, it was a crossover. Some people got oxytocin first, and some people got placebo first, and then they crossed them over, so everyone got to experience both. And the oxytocin intranasally increased their heart rate variability, which is very important and normal to happen during sleep. It increased their total sleep time, and it increased their self-reported sleep satisfaction. So they felt that they slept better after receiving the intranasal oxytocin than they did with placebo. Now, interestingly, again, most of you have probably had sleep studies with your child. You're familiar with something called the apnea-hypopnea index, and that's an index that's used to sort of grade a sleep study, how severe the sleep problems are. Apnea meaning you stop breathing, hypopnea meaning you breathe very shallowly. And although this index wasn't changed by giving the intranasal oxytocin, when they compared the apnea and hypopnea events independently of oxytocin versus placebo, what they found that the frequency of hypopneas, that shallow breathing, were significantly decreased with oxytocin treatment. This is, again, important because in infants especially, you're going to see much more hypopneas, much more of that shallow breathing. than you do true apnea. And so the fact that intranasal oxytocin can influence this is actually pretty important and significant. The other thing that I thought was really interesting in this study was that although it didn't actually change the number of apneas, it significantly shortened the duration of both the apneas and hypopneas with oxytocin treatment and decreased the arousal events. Again, this is something anybody who has a child with Prader-Willi knows, that they can wake up at 3 or 4 o'clock in the morning and be raring to go. And what oxytocin did was decrease that arousal, that waking up that comes from having some sleep apnea or hypopnea. So I thought that was a very interesting study. We actually have not looked at it in the oxytocin studies. They've all been way too short to look at this. This is a long-term significant finding with oxytocin, but I just thought it was really interesting. The other thing is the GI tract. As I mentioned, oxytocin receptors and oxytocin itself are expressed throughout the GI tract, and oxytocin does facilitate gastric emptying, which can be delayed and a significant problem, especially in adults with Prader-Willi syndrome, and improves GI motility, again, which can mean it can affect constipation. You're waving, you're directing. And so, especially in women, oxytocin can stimulate colonic motility, which again means that it can treat constipation with time, which is again a very important and significant potential issue in Prader-Willi syndrome. Interestingly, in the one study they did of a placebo versus intranasal oxytocin, they both improved constipation. However, oxytocin actually reduced the abdominal pain, the bloating, and the discomfort that was associated with constipation. And again, as part of the study, just like with the sleep one, they did some mental health indices, and they found that in both of these studies, both the sleep and the GI study, that intranasal oxytocin had a significant effect in reducing depression in both groups of patients studied. Now, again, these are not people with Prader-Willi syndrome. These are typical adults. But again, I think a very interesting finding, especially considering, again, the relationship between depression and GI problems, depression and sleep. So I thought those were interesting studies to include for you to know, because these are problems that we see in Prader-Willi syndrome. And then, of course, appetite, which is my big focus of oxytocin. In animals, oxytocin decreases the appetite for both carbohydrates and sweet tastes, which is super important in our individuals with Prader-Willi syndrome. We all know well that the appetite is driven by sweet taste. It's why we recommend no sweeteners at all in food. Don't put a flavor in a drink. Don't put, a sweetener, even if it's an artificial sweetener, to make your child eat or drink something, because it actually starts to rev up the appetite. And so oxytocin actually will decrease their desire for those type of foods. Interestingly, the effects of the oxytocin depended on the meal composition and the perceived reward value of the food. What this means is that if I gave you a plate of broccoli and green beans and gave you some intranasal oxytocin, it's not going to change how much of that broccoli and green beans you're going to eat. What it did change was those high reward foods. That's what it decreased. So in other words, if I were to give somebody with Prader-Willi a piece of chocolate cake, which I would not do, but if I did it, then and gave them some intranasal oxytocin, they actually wouldn't eat that whole piece of cake. They wouldn't find as much reward value from it, and they would actually push it away, just like they might do with their green beans and broccoli. So again, the value of what you're giving them actually affects how much the oxytocin affects their appetite. This is important because in a lot of studies, patients will say, well, it didn't actually change the appetite. Well, that's because we're not giving them these foods that are highly rewarding to them. We're mostly giving them, broiled chicken with, couscous and green beans or whatever. That's not highly rewarding for them, nor for us. And so therefore, you're not going to see much of an effect on the appetite on a day-to-day basis. What you do see an effect in is the anxiety that is associated with the appetite. This is just a picture of what's happening in the body, in the brain specifically, that the big blue square is the hypothalamus, and where oxytocin is released. And what this picture basically shows is that oxytocin, when given in the right situation, will increase satiety signals and decrease hunger signals, allowing for decreased appetite and food intake. But again, this is very variable and depends on specifically the composition of the meal. And again, this has been shown in multiple studies where they put people at buffets, and depending on what the food is that they're offered, it depends on how much the oxytocin will affect their appetite. So when oxytocin and why oxytocin? Well, I've told you the whys. And so we think that there are periods of time in the lifespan of Prader-Willi where oxytocin is going to be most important. One is, as I told you, the babies. So prior to 6 months, we know that most individuals with Prader-Willi syndrome have a lack of interest in eating. Again, I think this may be related to that AVP system being off. They also don't have a normal thirst. And when you're a baby, all your food is given via drink as milk. And so we think that giving intranasal oxytocin to babies can help improve the interaction with their parents, as well as or specifically they say mothers, but it actually is fathers too, and increase their desire to eat normally. I've long been a proponent, because of Tony Holland's work in the early 80s, that the quicker you get your infant with Prader-Willi syndrome eating typically and teaching them hunger and satiety signals and how to respond to those, the better off you're going to be in the long run. The other piece of this, though, is the older individuals with Prader-Willi syndrome. So as individuals get older, at around age 5, as you know, they can develop some anxiety, some autistic-like features in terms of, sort of compulsive behaviors, obsessive compulsive behaviors, if you will. And so as they especially get older into the teenage years, you'll often see emotional lability. So kids that will turn on a dime and cry when, a little stressor happens that you think, shouldn't have caused a problem. There's a lack of trust. You see this, I've always thought of the repetitive questioning as being sort of an obsessive compulsive thing, but it is also a lack of trust. They don't know that you're going to deliver on what you say you're going to deliver on. And so it becomes, are you sure we're going? Are you sure we're going? When are we going? Where are we going to go? When are we going to get there? What color is your kitchen? My favorite question I ever got. And so that oxytocin can improve their trust in others. Many of my patients will say, well, my kid is like the king of the school. Everybody likes him and he likes everybody. And so clearly he's got a lot of trust in people and a lot of good social skills. Being social does not equate to trusting people, nor does it equate to truly being a friend. And what oxytocin can help with is that piece of trusting other people, that piece of letting someone in and being their friend and being able to socialize with them in a normal way, which I think is very important as individuals with Prader-Willi get older. So there's a lot of issues in Prader-Willi syndrome that I think could be helped with intranasal oxytocin. And this is just some data from the Vanderbilt group that I think is actually super important data. So the parents and the siblings report that there's a lot more worry, anger, marital strife, inconsistent parenting in families with Prader-Willi syndrome than those with other genetic syndromes like Down syndrome or autism. Siblings of individuals with Prader-Willi syndrome are 92% more likely to have post-traumatic stress disorder symptoms than are children with other complex problems, again, like schizophrenia, complex congenital heart disease, things like that. Prader-Willi syndrome is hard. It's hard on everybody. And so to me, this is one of the main reasons to use oxytocin in this syndrome is not, I'm not going to give it to the parents and the siblings, although, Dr. Butler did get a lot nicer when he was inhaling some during our first study. But that being said, we think that by giving it to individuals with Prader-Willi syndrome, it actually is going to decrease a lot of these things that you live with on a day-to-day basis that increase your overall stress and anxiety in your lives, especially your home lives. That increased stress and well-being is actually very strongly correlated with how the child is doing. So the more behaviors they're having, the worse your life is. That is a statement that needs not saying, but I put it in there because it's in the paper. And that, these features, these ones that cause this post-traumatic stress stuff and the worry and the anxiety and the marital problems, these are autism type features. And these features, along with the appetite, are what limit the ability of these individuals as they become adults to function independently in society. As you all know, I truly expect that this generation of children will be more independent than in the past, and I want that tremendously. But it is a function of affecting both the behaviors, how they respond to other individuals, their anxiety, their stress, their compulsiveness, as well as their appetite. Okay, that being said, we're going to go through appetite really quickly, just so you know where we're targeting oxytocin. So there are actually 4 phases that I think oxytocin is really important to target individuals with Prader-Willi syndrome at. The first is that phase 1A, when they don't have the desire to eat. We all are familiar with this phase where they have to have a G tube or an NG tube. They don't cry for food. They push the bottle out. They're not excited to eat. Again, we want to normalize this as quickly as possible. It's one of the reasons that I've been such a strong proponent of early growth hormone therapy in infants with Prader-Willi syndrome, is because it does help their strength for eating, and it does help normalize quicker the appetite in the babies. And so it's why I push so hard for as many babies as possible to be able to get on growth hormone therapy. Oxytocin in conjunction with growth hormone could be tremendous in terms of reducing phase 1A. Phase 2A is the next phase where it could be important. Now, we have not tested it in phase 2A because at that point, really, these kids are very, very typical. And you all know this. They're about 18 months to 3 years of age, and this is just when the weight begins to change without a change in the appetite. So they're not more hungry, they're not seeking food, they're not talking about food. It's just that giving them the same food results in weight gain. And we think because oxytocin does have an effect specifically on an enzyme from the muscles called AMPK, that potentially targeting treatment even very early here before the appetite becomes an issue may actually affect the natural history of the syndrome. Phases 2B and 3 are where the studies are primarily focused. And this is when, in phase 2B, when that appetite starts to crank a little bit, this is when you see a lot of anxiety, not just about food or even really necessarily about food at all, just a lot of anxiety, a lot of questions. It can revolve around food. Are you sure you packed my lunch? Can I see my lunch? Can I make sure what you put in my lunch? Did you remember to put that in my lunch? But it also is around everything else in their lives. And you all probably live that on a constant basis after age 5. And I am often heard to say I would drink heavily if I lived in some of these families because it makes me a crazy person because I have no patience. But this is where we're primarily targeting the treatment. Ideally, I'd like to target treatment in phase 2B before individuals get to phase 3, which is the insatiable appetite phase. However, we are working on that phase as well. I'm a pediatrician by nature. I like to be preventative as much as possible. And so I want to try to prevent phase 3 as much as we can, especially in these younger individuals. So to date, there have been 5 oxytocin clinical trials that have been reported. There's been a couple more that have been done but have not been reported. I'm not sure why, but there have been 5 that have been reported. 4 of the 5 reported improvements in behavior in individuals that were treated with intranasal oxytocin versus placebo. One of them, which was Dr. Einfeld's study that I'll get to in a few minutes, done in Australia, was done in adolescents and adults with Prader-Willi, and actually showed some worsening of temper tantrums and behaviors with oxytocin versus placebo. There were some limitations in a lot of these studies. And so some of them didn't have a placebo arm. They were just a single dose of oxytocin. Some, the oxytocin dose was cranked up too high. The problem with oxytocin studies, quite honestly, is we don't know the right dose. because it's a very individualized treatment. Every person is an individual, every person responds differently, and that makes treatment trials very hard. It's one of the reasons why Novartis really doesn't want to touch us with a 10-foot pole, because the treatment is not going to be weight-based or body surface area based. It's going to be individually based, and that makes it hard to run a trial. That being said, most of the doses were picked out of the air, basically from mouse study research, and so not exactly the best way to pick doses for humans, but nonetheless, what happened? There were 2 studies in children, the one done in the Netherlands by Anita Hoken's group, and the one done in the United States by our NIH-funded clinical trials group, that were double-blind, placebo-controlled crossover studies. And these studies showed that in the younger individuals, ages 5 to 11 with Prader-Willi syndrome, there was improvements in both behaviors and appetite. Dr. Hoken's group did a little bit of a longer trial than what we did. They did a 4-week trial, and they found definite improvements in appetite in the younger individuals. We did a 1-week trial. We didn't see as much. We did see some signs of improvement in appetite, but primarily what we saw decreases in was repetitive behavior and anxiety. The picture at the bottom of the screen there is 2 little boys who were in the trial. The parents took this picture because they said it's the first time they've ever played with another person, like actually played and interacted and taken turns, which I thought was kind of cool to see. The infant study that Dr. Taubert did in France a couple of years ago, that was just published last year, did not have placebo controls. Everyone was treated with oxytocin, which does tend to give you some skewed results. And we have done the placebo-controlled trial here in Gainesville and for infants, and the results are currently in review. I can't share them because the paper is not yet published. It's being reviewed right now, but I will say that it is done, and we do have those results. This I just thought was an interesting picture. This is functional MRI, and what it shows is, you're giving intranasal oxytocin, and everyone wonders, is it for sure getting into the brain? And this is a functional MRI picture showing blood flow in areas of the brain, and what you can see is it most definitively is. You're getting increased blood flow in various areas of the brain, specifically that front part of the brain there on the top picture, which influences decision making. It's your executive function part of your brain. So the potential is there for it to potentially help individuals with Prader-Willi make better decisions and not be as impulsive, which is a really significant thing if it does bear out. Now, I mentioned earlier the Einfeld study, which was one that showed negative results. Stuart Einfeld is based in Australia, and he did a study for individuals with Prader-Willi syndrome who were ages 13 and up. And what he did was he treated them using 18 IUs twice a day for the younger individuals and 24 IUs twice a day for the older individuals. Dr. Taubert, Dr. Hoken, and I all have used in all of our studies 16 IUs once a day. And the individuals who have been on oxytocin clinically in Europe for several years, which I'll talk about in a minute, have been on it like once a week to once every 3 days. So twice a day dosing at this high of dosing is really high. And what they found was there was no positive effects. So they tried to increase the dosing, and then they got negative effects. And they got worsening behaviors, like increased temper outbursts and increased food problems. And so, again, I mentioned at the beginning that oxytocin can bind those arginine vasopressin receptors, those AVP receptors, which have the opposite effect. They increase paranoia and behavioral problems. And this is what we think happened here, that when they were treating with twice a day dosing, that they were equally probably binding oxytocin and vasopressin receptors. And when they increased the dosing, now all of a sudden they were binding vasopressin receptors even more. And so they started to get some negative behaviors in that study. We would rather not try that out because we don't really want negative behaviors, but that's what we think is going on here. Anecdotally, we have several patients who are on oxytocin and have been for years in Europe because you can get oxytocin from Novartis with a prescription. And anecdotally, those individuals have a decreased appetite and increased social responsiveness overall. But what we have found is that there is a need for a washout period. Again, every individual is an individual. And that if you treat with oxytocin consistently over time, you do bind up all your oxytocin receptors and start to bind the vasopressin receptors, and then you start to get problems. And so it's very important to remember that oxytocin can bind these receptors, and that over time you're going to bind these receptors. It's unquestionable. And so you can't just treat and continue to treat. You have to treat and wash out every so often. The longest duration anyone's been on treatment so far is 5 years. That individual has been on treatment once a week for a couple years, is on treatment now once every 3 days at age 9. And we wash that individual out about once every 6 months. We take the person off for 2 weeks at a time to sort of reset the system and reset those oxytocin receptors. There have been 3 boys in the US who have more profound autism features than Prader-Willi features. And these unfortunate individuals couldn't get into any of the studies because they have a dual diagnosis. They couldn't get into oxytocin autism studies because they also have Prader-Willi. They couldn't get into Prader-Willi studies because they also have a diagnosis of autism. And so these parents were really tied in terms of how were they going to help their children. And it just so happened that one of the mothers has a family member who's a physician in Europe and was able to get some intranasal oxytocin and treat these individuals and provide it to these individuals under my guidance. And what we have seen in those 3 boys, and those boys, by the way, are ages 7 to 14, or 13, I'm sorry, 7 to 13. And what we've seen is that those individuals had improvements in social behaviors, repetitive behaviors, as well as appetite, drive, and weight control. I just saw one of them recently. I was telling my husband, it's funny how parents forget because you come to a new normal. And this is why I write everything down, because I also will forget stuff. But, you know, I'll talk to these families and I'll have written down that this kid said to me last year 125 times, "Hello, Dr. Miller, how are you today? Hello, Dr. Miller, how are you today?" And this time he said it one time, I answered him, and he moved on. And the parent said, "It hasn't really done anything." And I just about fell on the floor because I was like, it actually really has done a lot. You know, he only asked me one time, that's really significant. And so, but because it's become their new norm, to them, it hasn't done anything, but it really has significantly improved the behaviors of these patients. These are one of the sets of parents at the bottom there who had oxytocin tattooed on their legs because they were so excited by the response that their child had. The longest duration of treatment of these 3 boys with autism is 1.5 years. And I will tell you that none of them have needed dosing more often than once every 3 days. And some of them only need dosing once every 5 days. Now, this is really interesting because oxytocin theoretically should only last in your system for a few seconds to minutes. But yet in Prader-Willi syndrome, the effects last for days. And it's important to know because one of the families, this family actually who has tattoos, decided that they were going to make things better because if some is good, more is better. And they didn't have a perfect child, so they started to treat every day, at which point their child threw a chair through the window of a school and beat the teacher up. And so showing them that indeed in this particular case, more is not better, that too much oxytocin actually causes quite significant problems and worsens the problems that you have, probably even worse than they were before. So carbetocin is a super interesting molecule, was developed actually in the lab by a dad who has a child with autism. He knew the risks of oxytocin, that it could be overdosed and bind to the vasopressin receptors, so developed a molecule that is a selective agonist for the oxytocin receptor. In other words, it cannot bind the vasopressin receptors even at high doses, so you can't overdose on this, which is excellent. This was initially marketed by Ferring Pharmaceuticals and bought up this year by Levo Therapeutics, which is owned by a mother of a child with Prader-Willi syndrome. And they have initiated development of carbetocin for treatment of both appetite and repetitive anxiety behaviors in children and adolescents with Prader-Willi syndrome. We did the initial phase 2 study along with Vanderbilt and Dr. Angulo in New York in 38 patients with Prader-Willi syndrome ages 10 to 18. It was really impressive data. The paper was just published. Elizabeth Dykins is the first author. And what we found was that it definitely decreased hyperphagia and improved both the compulsive and the repetitive behaviors. It was literally so stunning that we would always bring in patients as a group, and they would be in one big room in our research center, and parents by day 2 could go through and say, drug, placebo, placebo, drug. I mean, they could tell who was on drug and who was on placebo by day 2. And the way they could tell was at 10 o'clock. We did not hear, Dr. Miller, it's 10 o'clock. 10 o'clock is snack time. Dr. Miller, 10 o'clock. We heard, you want to play a game? Do you want to do homework with me? So they were definitely able to have a reduction in that level of anxiety, which is huge. And I believe that translates into a reduction in food behaviors as well. The phase 3 study is going to contain 175 patients ages, I believe, 8 to 18, and should start hopefully next month. We're very excited for this study because the hope is with a phase 3 this large that we will be able to get approval relatively quickly through the FDA. It's a very safe molecule because it only binds the oxytocin receptors and is given as a nasal spray. So the really only side effect that has been noted is that it can cause some nasal irritation because you're spraying it up the nose. So other than that, though, it was really safe with no side effects, and we're excited to start the phase 3 very soon. So that is the end of my oxytocin trial, and I think I got pretty close to my time. And, I just want to say that although the world is changing, and I'm really super happy about the world and how it is changing right now with Prader-Willi syndrome, we still need an effective treatment for the appetite specifically. We need an effective treatment for several of the features, as I mentioned, but really the appetite. We don't want to make these individuals live in homes that are prisons and make the rest of the family responsible for tattling when the child gets into food. We want these individuals to be able to live healthy, independent, productive lives and be productive members of society. And that's why we do what we do, because we want to find a way to help these individuals be successful in this world. And that's all I have. Thank you.
We've got 2 or 3 minutes. Does anyone have any particular questions? Yes.
Assuming that carbohydrates gets FDA approval, how long will it take for something that's been approved in the States to be
Oh, I don't know if you're ready.
I'm not sure that you can answer this. So
I can't answer it. I heard the question. Thank you. But I don't know the answer. Our hope is that they will actually be targeting European trials at the same time for EMA approval as well. So I know they're going to start with the US, and depending on how that goes, my thought or my understanding is the plan is to do European trials very soon as well, to try to get EMA approval within a very short period of time around the FDA approval.
the other thing I would say is that one of our trustees is in talks with Sarah Cotter from Levo Therapeutics, and we're also trying to bring it to the UK. I know she's very keen on it coming out into Europe, so if we can possibly get any trials done in the UK, we will. But if it gets agreed and FDA approval, we will absolutely be on it to try and bring it to the UK.
We've got a question just over here.
We've got a question at the back.
yes. Is that working?
No. I can repeat it, so
Should I just shout?
Yeah.
yes.
Okay. Is this information about oxytocin likely to mean we need to adjust how we care for neonates with Prader-Willi syndrome? So things like more skin to skin or donor breast milk and things like that, because we know that has a huge impact on oxytocin.
So the question is, this knowledge about oxytocin, does that change how we should look after neonates and whether we should increase the skin-to-skin contact, all of that sort of thing, which we know does help with the bonding?
Absolutely, absolutely. Breast milk also, even though it's you can't obviously breastfeed an infant with Prader-Willi syndrome because they don't suckle well. But giving them breast milk also increases their oxytocin exposure. Skin to skin definitely increases their oxytocin exposure. Apparently, looking in a dog's eyes also increases their oxytocin exposure. So I'm not saying everyone should get dogs, just throwing it out there.
Sorry, what was that? What was
But
it? What did she, could you repeat that?
Could you repeat that? We lost that last bit.
Oh, sorry. It was a joke. No worries. But I would say that definitely it should change how we think about neonates. That we should strongly encourage skin to skin. We should encourage awakeness as much as possible when they're awake to be in their face, bonding and interacting, and to be giving breast milk as much as humanly possible.
Thank you.
Oh,
We've got one more question here in the middle.
Yeah, hi, Jennifer, it's Ruth, Lilu's mum.
She says it's Ruth Lilu's mum.
Lilu's mom, I heard her, yes.
Hi, I just had a quick question about overdosing on oxytocin, because as you know, Lilu took part in my Talba's infant study. I also breastfed Lilu and did loads of skin. I'm having major issues with Lilu with feeding in the opposite sort of what I should have. She's not feeding correctly. Do you think that could be because of oxytocin? Because maybe, so she was in the trial, she was the one that had the most dosage. She was on a double dosage a day. I don't have any of the other sort of negative effects with Lilu, but again, I do have major issues with her feeding. So do you think that could be a result from oxytocin and an overdose of oxytocin?
Did you hear the question?
I did. It's a really interesting question, Ruth, and I've been thinking about it a lot since you emailed me that question because I don't know the answer, but my gut feeling is that you're probably correct, although I don't know that. But that maybe that high dose of oxytocin that she got along with the oxytocin that she was endogenously producing from the skin to skin and from the breast milk maybe did have a significant effect on her appetite. We do, however, and this is where I run into what is what, when somebody's been in a clinical trial. We do have kids that do have feeding problems at her age, that just don't eat well. And we struggle to get calories in them. And so, they're few and far between, but they're there. And so she may just be one of those children, or it could be the oxytocin. My gut feeling is that I agree with you. I think the oxytocin probably played a role. And what that means in terms of the future for her will be interesting to see. Will she end up not having appetite problems in the future? I don't know the answer, but I know as a toddler, it's got to be exceedingly frustrating to not be able to get the nutrition she needs into her because she won't eat well, and so I think, unfortunately I don't have an answer, but it's a really, really good question because as studies are going on, people are, of course, going with the if a little is good, more is better philosophy, and that actually could end up being, having these consequences for other children as well. The oxytocin system is set within the first 6 months, and so and she was under 6 months when she participated, so it's very possible that did happen. But I can't answer the question, unfortunately.
Thank you. Last questions.
Just listening to the slides there and Dr. Miller speaking, in comparison to oxytocin, carbohydrates sounds quite less problematic. So given a successful trial with carbohydrates, would that look to replace oxytocin together? And then sort of the second part is, can that be given to all age groups, carbohydrates, or is it specifically for older children?
So it's a very good question, and the answer is yes. I think that carbetocin will replace oxytocin ultimately in terms of studies because it's safer. But the age phenomenon, we don't know. Our suspicion is that it should be able to go low as well. And I've talked to the FDA specifically, and I know Dr. Gobert has talked to the EMA. about carbetocin for babies to see if the effects are the same with carbetocin as they are with oxytocin. They're waiting for the safety data from the phase 3 before they'll translate to babies, but the plan is exactly that, to translate it across all age groups.
Thank you very much indeed, Dr. Miller. Thank you. That was an absolutely wonderful presentation. We've all learned a huge amount.